Hi, good evening, everyone. Today's topic is MR imaging based diagnosis and classification of the meniscal tears. Before, one sec. Before knowing, the diagnosis of and classification of the meniscal tears based on MRI characteristics, we need to know the normal anatomy and some variants. So the accurate and timely diagnosis of the meniscal tear is very critical for reducing the morbidity and for planning of the treatment. The meniscal damage predisposes the adjacent articular cartilage to increased axial stress and shearing injuries, resulting in early degenerative osteoarthritis. So our main goal is to understand the normal meniscal anatomy and normal variants and pitfalls, and to summarize the criteria for MR imaging diagnosis of various patterns and classification of the meniscal tears. The diagnosis of most common tear patterns seen at MR imaging should be described, including whether it's a horizontal type of tear, longitudinal, radial, root tear, or whether it's a complex tear, whether the fragments of the menisci are displaced or not, and like any bucket handle tears, etc. So an accurate and precise diagnosis can basically facilitate the pre-surgical planning and prevent unnecessary surgical exploration or repeating surgery. So let us come to MR imaging parameters. The spatial resolution of the scan can be improved by maximizing the matrix size while maintaining a small field of view and also preferring the thin sections. The typical parameters include a field of view of about 16 to 20 centimeters, or sometimes less, other is 12 centimeters, and average section thickness of around 3 to 4 millimeters. And the accuracy of the MR images for tear detection is compatible at the field strengths ranging from 0.1 to 7 Tesla. However, the higher field strengths often improve the spatial resolution and also gives the reader a good confidence and also grossly reduces the image acquisition time. So let us go to normal anatomy. The menisci function is basically to absorb the shock and distribute the axial load as well as assist in joint lubrication and facilitate the nutrient distribution. The medial meniscus and the lateral meniscus are wedge-shaped and semilunar. They are wedge-shaped and semilunar in their shape, which are the fibrocartilaginous structures. And each meniscus usually have a superior concave. You can see superiorly it is concave pattern and a flat base. So this flat base basically attaches to the tibia via the central root ligaments. So as a result of these concave structures, it has got a peripheral thicker portion and a tapered, smooth central free edge. So the circumferentially oriented type 1 collagen fibers bundles will provide the menisci hoop strength, and which is very critical in resisting the axial load and preventing the meniscal extrusion. So the thinner, these are the collagen fibers which will provide the hoop strength, which will give maximum stability to the menisci. And in between these collagen bundles, we will see a thinner radial fibers, which are actually perpendicular to these circumferentially oriented bundle of fibers. So these radial fibers will, they'll usually form a lattice along with these the collagen bundles and give maximum strength and structural support. See, each menisci can be divided into on cross-sectional. This is a semilunar structure of the menisci, and the meniscus is subdivided into the anterior horn, the posterior horn, so which are basically attached to the tibia through the root ligaments. Posterior root, that is anterior and posterior root ligaments. These are the anterior and posterior roots of the menisci. Through the root ligaments, the meniscus attaches to the tibia. And And this is a sagittal PD weighted MRI image. It will show a striated pattern of the anterior horn of the lateral meniscus that is due to contributing insertional fibers that originate from the ACL. At MR imaging, the menisci always appear low signal intensity structures, especially on sagittal images, the menisci appear a bow-type pattern. On coronal images, the menisci appear either triangular or wedge-shaped depending on whether the imaging plane is through the body or the horn respectively. Although the menisci have similar composition and signal intensity, they are little distinct. That is, the medial meniscus is less mobile because of its peripheral attachment to the deep fibers of the medial collateral ligament. In addition, the medial meniscus has more open C-shaped configuration. This is the sagittal PD weighted images that show a typical bow-type configuration of the menisci. That is, the body of the menisci, anterior and posterior horns of the meniscus, the lateral meniscus, and this is the anterior and posterior horns of the medial meniscus. Usually, the posterior horn of the medial meniscus is larger than the anterior horns. But in case of the lateral meniscus, both the anterior and posterior horns are almost same in size. On coronal PD images, we can see triangular morphology of the meniscal body. So this is the body of the meniscus and coronal images, which has got a triangular pattern, but has got a elongated, you see, wedge-shaped posterior horn that in contiguous with the root. Okay, this is called the meniscal root, where it is the attachment site to the tibia. Then in newborns, the peripheral 50% of the meniscus is vascularized. This is called the red zone by the perimeniscal capillary plexus. So the degree of vascular penetration declines with the age to about 10 to 30% in adults. So this vascular distribution supply of the blood supply of the periphery of the meniscus by the perimeniscal capillary plexus contribute to the spontaneous healing of the peripheral tears, and also sometimes the increased signal intensity of the periphery of the menisci in children. So come to the surrounding anatomy. The common anatomic structure that can mimic the tear include the transverse meniscal ligament, the meniscofemoral ligament, the popliteomeniscal fascicles. So the transverse meniscal ligament, also called ligament, is a thin fibrous band that is almost present in 90% of the specimens and 83% of the MR imaging studies. It connects and stabilizes the anterior horns of the medial and lateral menisci. On the sagittal images, this transverse ligament, that is transverse anterior ligament, can simulate the anterior root tear. So before telling the tear, we have to see this, see the menisci both on sagittal as well as the axial images. So on sagittal PD image, an apparent anterior root tear, which is followed by multiple imaging sections and better depicted. So I mean to say that it can give a false positive appearance of a tear. So better we confirm the axial images on the visibility of the meniscal ligament. So on next, let us come to another ligament. That is on PD weighted images where we are seeing low signal intensity structures anterior as well as posterior to the PCL. This is the PCL, anterior and posterior. So anterior one is called as the Humphrey, ligament of Humphrey, and one which is present posterior to the PCL is called as the Wisberg ligament. So at MR imaging with fluid sensitive sequences, the anterior, another thing is the meniscal fascicles. So these are the meniscal fascicles. So they are synovial lined fibrous bands that attaches to the lateral meniscus posterior horn and help from popliteal hiatus. They stabilize the posterior horn and also helpful in controlling the motion. Okay, here a sagittal PD weighted image shows focal fluid signal intensity in the posterior superior aspect of the lateral meniscus. So they are called as the fascicles, meniscal fascicles, which is also seen at the roof as well as the floor of the menisci. So this should not be confused with the tear. Okay. Another anatomic variant and pitfall is to know the pattern of the meniscus, that is the anatomic variants of the meniscus, that is the discoid meniscus, the meniscal fluence, a meniscal article, and chondrocalcinosis. So the discoid meniscus, as the name represents, an enlarged meniscus with further central extension of the meniscal portion into the tibial articular surface. It is seen in 1 to 5% of the knees and is 10 to 20 times more common in lateral meniscus compared to the medial meniscus. So one of the well-practiced classification divides the discoid meniscus into a complete variant has a block-shaped meniscus that covers entire of the tibial plateau, and a partial variant has a meniscus that covers up to 80% or less of the tibial plateau. Other one is called Wisberg variant, with a thickened posterior horn, lacks the normal posterior meniscal attachment, and can cause snapping knee syndrome. So this is the pictorial diagram showing the types of the discoid meniscus. So this is the normal variant where we'll see a C-shaped meniscus. Okay, and here we can see an incomplete type of discoid meniscus, which is slightly thicker, than thicker as well as the wider than the normal. This concavity is not there in complete variety. In complete variety, the meniscus completely covers the tibia without concavity. In hypermobile variety, which occurs when the meniscofemoral ligament that attaches to the meniscus to the tibia is absent. Without this meniscofemoral ligament, even the normally shaped meniscus can sometimes slip into the joint and can cause pain, locking as well as the popping of the knee. For example, in the coronal images, you can see how there is a tapering of the body of the meniscus on one side, but on the other side of the lateral meniscus, we can see the menisci which is discoid, and it is extending almost to the intercondylar region. So the important thing is the discoid meniscus is more prone to the injury than the normal menisci, and it is usually thick, as the name indicates. That's a discoid meniscus, and it's more commonly gets stuck into the knee and cause a tear. Once injured, even a normal meniscus is difficult to heal. This is because the meniscus lacks strong blood supply, and the nutrients are essential to the healing cannot reach the injured surfaces. But in case of the kids, the peripheral tears will heal better because of the meniscal plexus which are seen in the periphery. But in case of the discoid meniscus, patient actually experience the symptoms even without being any injury to the meniscus. Come to the meniscal fluence. The meniscal fluence is a rippled appearance of the free non-anchored inner edge of the medial meniscus, which can be seen in up to 0.2 to 0.3% of asymptomatic knee. Typically, this is secondary to flexion of the knee and redundancy of the free edge of the medial meniscus. The distortion of the body, the meniscus does not indicate a tear, but however, on the coronal images, it may simulate truncated meniscus and mimic the radial tear. On arthroscopy, the fluence sign is more common because of knee positioning, and anesthetic relaxation usually signifies the absence of the tear. You can see a body of the meniscus giving a ruffled appearance, that is the inner margin. Before, they used to think that they are the radial tears, but with arthroscopy and better MR imaging modalities, we can differentiate the the meniscal flanges from the radial type of meniscal tears. So it's one of the normal variants. So before considering the tear, we should always see it on both sagittal and coronals. Next thing is meniscal ossicle. Is a rare entity with a predilection for posterior horn of the medial meniscus. So the cause of meniscal ossicle could be developmental, degenerative, or post-traumatic. On radiographs, the ossicle can be mistaken for a loose body, while at MR imaging, its increased signal intensity can mimic a tear. So review of the patient's radiograph can prevent the false positive diagnosis of the peripheral tear or parameniscal cyst. And also we need to correlate with the clinical symptoms. So we can see here narrow signal intensity within the posterior horn of the medial meniscus, but on radiograph we can see that it very well correlate with the meniscal ossicle. It's not a tear or parameniscal cyst. Come to chondrocalcinosis. It is a generic term referring simply to visible calcification of both hyaline and fibrocartilage. It basically occurs due to calcium crystal deposition and deposition of the calcium salts within the menisci, causing calcification. So it can, and it can give apparent increase in meniscal signals, thereby lowering the sensitivity and the specificity of MR detection of the tears. So its prevalence increases with the age from 5 to 50%. Once again, correlation with the radiographs, we can see that calcification of the menisci here, so that even though it will give the false positive increase the signals in the menisci, we can rule out and tell it's not a meniscal tear. So come to the classification and pattern of tear. So the prevalence of the meniscal tears increases with the age, and the meniscal tears are often associated with and contribute to early degenerative joint disease, and are more common. The meniscal tears are more common in the posterior horn of the meniscus, particularly favoring more constraint to medial meniscus. However, in younger patients with an acute injury, lateral meniscal tears are also seen. In the presence of ACL tears, there is increased prevalence of peripheral tears and decreased sensitivity for detection of the lateral meniscal tears at MR. Therefore, special attention should be directed to the location whenever there is a subtle peripheral tear may be present. Remember, the normal meniscus should always have a low signal intensity on MR imaging. However, globular or linear increased intrameniscal signal intensity can be seen in children. That is due to peripheral vascularity, that is perimeniscal plexus, and also in adults it can be seen sometimes, which could be due to mucinous degeneration. However, but sometimes after the trauma, immediate acute trauma, we can also see the high signal intensity in the menisci. So for diagnosing a tear, meniscal tear, it includes the distortion of the meniscus in the absence of prior surgery, or increased intrasubstance signal equivocally contacting the articular surfaces. So if these criteria are seen in 2 or more images, that is fulfilling the 2-slice touch rule, then positive predictive value for a tear is around 94% in the medial meniscus and 96% for the lateral meniscus. Means you should see, and also the findings must be identified in the same area in any other 2 consecutive MR images, which can be either 2 coronal images or sagittal. So we should see a tear in all the sequences. We should not come to conclusion and classify a tear with one, either looking at the sagittal or looking at the coronal alone. We should try to see the tears in all the planes as well as in different sequences. So in contrast, increased intrasubstance signal intensity without extension into the articular surface is often not associated with a tear at the surgery, nor has it been shown to progress to a tear. So the importance of the sections is Most tears can be confidently diagnosed on sagittal images or coronal images. However, coronal images are also important for confirming and accurately characterizing the various tear patterns. So first you try to see the tears on sagittal images and try to confirm it on coronal images. Small radial tears, horizontal tears of the body, and bucket handle tears may be difficult to reliably detect on sagittal images because of volume averaging. So in case of small radial tears, horizontal tears of the body, and bucket handle tears, try to depict and see the findings on coronal images as well. In addition, sometimes axial images are very helpful in detection of small radial tears or displaced tears or peripheral tears of the posterior horn of the lateral meniscus. So these meniscal tears can be treated with conservative therapy, surgical repair, or partial or complete meniscal resection, torn meniscal resection. The longitudinal tears are often amenable to repair, whereas the horizontal and radial tears may require partial meniscectomy. So whenever a tear is identified, accurate description of its morphology is important so as to plan the treatment. So the most common tear patterns described are either horizontal tear, longitudinal tear, radial tear, root tear, complex tear, displaced, and bucket handle tears. These are the terminologies we need to use while describing a tear in the impression of the report. Come to a horizontal tear. This horizontal tear always runs parallel to the tibial plateau and involves either one of the articular surfaces or central free edge horizontal. So, and always extends towards the periphery, dividing the meniscus into superior and inferior components. That is, it runs through from peripheral edge to free edge. And these horizontal tears usually occur in older patients above 40 without any trauma, or more common in degenerative joint. The typical MR appearance of horizontally oriented line of high signal intensity that contacts the meniscal surface or the free edge. The parameniscal cyst formation is associated with complete horizontal tears that extends to the peripherally. Secondly, to direct communication of the tear to the joint fluid and then seepage and forming of the cyst. So the treatment often involves the debridement of the smaller unstable meniscal leaf as well as decompression of the associated parameniscal cyst. This partial meniscectomy with open surgery can be shown. Partial meniscectomy is the mode of treatment. Here, an arthroscopic image shows a typical horizontal tear that extends to the free edge, the tear extending to the free edge. So this is how a horizontal tear appear on sagittal images, where we can see at the level of the body a linear bright signal, and this is at the level of the horns. Similarly, on the coronal images, this is how the horizontal tear looks. So let us take the MR images. A sagittal T2 weighted MR images shows a tear of the posterior horn of the meniscus with a small parameniscal cyst. So similarly, the same horizontal tear on the coronal shows the horizontal signal in the body of the meniscus that contacts the superior surface. Here also peripherally, there is intra-articular extension with a small parameniscal cyst. This is the horizontal tear. Come to longitudinal tear. The longitudinal tear runs perpendicular to the tibial plateau and parallel to the long axis of the meniscus and divide the meniscus into central and peripheral halves. Unlike the horizontal or radial tears, pure longitudinal tears do not involve the free edge of the meniscus. These tears often occur in younger patients after significant trauma. and likely to involve the peripheral third of the meniscus of the posterior horns. And on MR, they typically see a vertically oriented line of high signal intensity that contacts one or more articular surfaces. This is a pictogram model view of a longitudinal tear. So the longitudinal tear extending to both the articular surfaces, that is superior and inferior articular surfaces, and running along the long axis of the meniscus, dissecting it between the longitudinal collagen bundles. Okay, and it separates, the longitudinal tear always separates the free edge from the periphery. Free edge from the periphery. Okay. There is close association between the peripheral longitudinal tears and the ACL tears. So peripheral longitudinal tears of the posterior horn of the lateral meniscus are often difficult to identify because of surrounding complex anatomy and posterior attachments. So identifying peripheral longitudinal tears of the posterior horn of the lateral meniscus can be difficult. Because of the other surrounding structures, anatomical structures, we need to carefully identify the peripheral tears, longitudinal tears. Come to radial tears. The radial tear runs perpendicular to both tibial plateau and the long axis of the meniscus, and it transects the longitudinal collagen bundles as it extends from free edge towards the periphery. So, in contrast to horizontal and longitudinal tears, radial tears disrupt the meniscal hoop strength, resulting in a dramatic loss of function and possible meniscal extrusion. So tears are frequently not repaired because they are located within the avascular zone, that is the white stone centrally, and therefore have low likelihood of healing because of less vascularity, less nutrition supply after repair. So this is a three-dimensional model of a radial tear that involves a free edge, and it is perpendicular to the long axis of the meniscus. It is perpendicular to the long axis of the meniscus. So these radial tears commonly involve the posterior horn of the medial meniscus or the junction of the anterior horn and body of the lateral meniscus. On axial images, these tears appear as a cleft that is oriented perpendicular, and it is seen as a cleft or marching cleft. Other signs includes a ghost meniscus sign. So here, this is how on sagittal images a classical radial tear appears. We can see a cleft in the body of the meniscus, and similarly on the coronal images we can see a cleft, or sometimes on the coronal images we can see a truncated appearance, or in sagittals we can see a ghost meniscus sign where the meniscus, there is a radial tear is there. Okay. Yeah. So the MR imaging signs of on sagittal PD weighted images we can see a cleft. Okay. The truncated appearance of a partial thickness radial tear or completely absence of the meniscus. You can see a cleft here is a truncated appearance or a ghost meniscus sign, which is called, where a full thickness radial tear involving the free edge of the meniscus. These all three signs suggest a radial tear. So marching cleft sign means the vertically oriented cleft that is marching from the free edges into the substance of the meniscus and involving both the articular surfaces. This is the classical sign of a radial tear. Here we are seeing a radial tear cleft at the junction of the anterior horn and body of the lateral meniscus. But remember, the axial images are very useful in detecting the radial tears, as in especially fluid sensitive MR image we can see a small cleft involving the free edge of the meniscus. So we need to make use of the axial images also for diagnosis of the radial tears. Okay, root tear. So a root tear is typically a radial type of tear. These root tears are many times underdiagnosed previously, but they have received increased recognition in recent years because of their previous underdiagnosis of both MR imaging or arthroscopy. And coronal images, the root should course over its respective tibial plateau on at least one image. On sagittal, I'll show the root tear images before that, a little bit of theory. On sagittal MR images, with the posterior root of the medial meniscus is not detected, just medial to the PCL, a root tear should be suspected. In addition, when an ACL tear is present, there is an increased incidence of lateral root tears. The acute root tears without significant underlying degenerative changes are often promptly repaired because the surrounding rich synovial blood supply will encourage the post-operative healing. See, this is a case of complete root tear where PD images show a complete absence of the root of the meniscus and coronal images. That is again confirmed on the axial images where there is a complete tear of the root of the meniscus posteriorly of the medial meniscus. So we have to look into both coronal as well as the axial images for diagnosis of the root tear. Come to a complex tear. A complex tear includes a combination of radial, horizontal, and longitudinal tears. Components. Often the meniscus appears fragmented and the tear extends in more than one plane. For example, this is an image of a complex tear where sagittal PD weighted MR images shows both the vertical component as well as the horizontal component. With this both vertical and horizontal component tears, the meniscus is fragmented with intra-articular extension of the tears. In this kind, we need to describe the pattern of tear in the body of the report, and in the impression we need to mention clearly as it's a complex tear because involvement of two kinds of tears with fragmentation of the meniscus. Okay, then displaced tear. Displaced tears includes free fragments, displaced flap tears, and bucket handle tears. These tears often manifest with mechanical obstruction and require surgical reattachment or debridement. Small free fragments and flaps can be missed at arthroscopy. Therefore, identification of these small fragments before surgery is must. Okay, and awareness of typical pattern of displacement is helpful. These flap tears occur 6 to 7 times more frequently in the medial meniscus, where in 2/3 of the cases the fragments are displaced posteriorly or medially in the intercondylar notch region or superior recess. In the lateral meniscus, the fragments are equally distributed along the posterior joint line and lateral recess. Okay. Here the coronal weighted image shows a complex tear of the posterior horn of the meniscus with fragments which are displaced medially towards the intercondylar notch. So we can call it as a complex tear with displacement of the fragments. So another image showing a large flipped fragment of the meniscus laterally. Okay, one more image showing a complex tear of the meniscus which is displaced posteriorly. Okay, come to bucket handle tear. So bucket handle tear is a longitudinal tear with the central migration of the inner handle of the fragment. So this is the meniscus where the tear has happened, and you can see a fragment of the meniscus which is torn is displaced medially. So this bucket handle tear pattern occurs frequently in the medial meniscus and has got other indirect signs. So we have to rely on indirect signs before diagnosing or deciding on the bucket handle tear, which includes absence of bow tie or a fragment within the intercondylar notch, double PCL sign, or a double anterior horn or flipped meniscus, or disproportionately small posterior horn of the meniscus. A bucket handle tear of the lateral meniscus can rarely manifest with a double ACL sign, whereas a fragment is located just posterior to the ACL. Although these signs are sensitive, they are not specific. For example, the absence of bow tie sign, where the innermost bow is not present, can also be seen as small or a pediatric patient and with a radial tear of the body, or macerated meniscus, or in case of partial meniscectomy. Similarly, the mimics of double PCL sign includes prominent ligament of Humphrey, or menisco-meniscal ligament, or intercondylar osseous bodies. So these signs, that is the absent bow tie sign, fragment within the intercondylar notch, double PCL sign, these are sensitive but are not specific. So this is the diagram of showing the bucket handle tear, where we can typically see a tear involves the majority of the meniscus with the medial displacement of this is the model diagram demonstrating the medial displacement or inner displacement of the handle of the bucket tear. This is the axial image where we are seeing a fragment of the meniscus which is displaced medially. Okay. Yeah. And another sagittal image shows a double PCL sign where a meniscal fragment is displaced anterior to the PCL, which is giving a double meniscus sign. Okay. So indirect signs of meniscal tears. Secondly, indirect signs of meniscal tears are what happened? Used or better established indirect signs of meniscal tear includes the parameniscal cyst, the meniscal extrusion, or subchondral marrow edema. The parameniscal cysts are distinguished from the bruise and the ganglion cysts by their intimate association with the meniscus, either through direct contact or via the fluid tract. They represent the peripheral escape of the joint fluid through the meniscal tear, which typically contains in a horizontal tear. I mean, more common in the horizontal tear. Then disruption of the circumferentially oriented collagen fibers results in the loss of the meniscal hoop strength and subsequent extrusion. When we call it as extrusion, extrusion is present whenever the peripheral margin of the meniscus extends 3 millimeters or more beyond the edge of the tibial plateau. We have to approximately. So indirect sign, whenever the meniscus is extruded more than 3 millimeters beyond the tibial plateau, we call it as extruded meniscus. That is an indirect sign of the meniscal tear. Next one is the subchondral marrow edema. So linear subchondral bone marrow edema is also one of the indirect signs. Whenever superficial bone marrow edema, that is adjacent to the meniscal attachment site, it's parallel to the articular surface, where its depth is less than 5 millimeter, we have to suspect the meniscal tear, because the marrow edema can also be seen in case of the contusions, but it's not superficial. Many times it will be patchy secondary to the trauma. So the parameniscal cysts or exclusion of the meniscus or subchondral marrow edema, which is less than 5 millimeter deep, also to be considered while looking for the indirect signs of meniscal tear. So to conclude, the two-slice touch rule, that is MR imaging, has high accuracy for preoperative detection of the meniscal tears. In addition, it also allows us the accurate characterization of various tear patterns, which can be instrumental for patient counseling and surgical planning. So familiarity with the normal anatomy, common anatomic variants, and indirect secondary signs of meniscal tears is very helpful to avoid the interpretation errors. Thank you.